As we celebrate love and matters of the heart and Black History Month, let's also channel our passions towards a cause that's close to our hearts, combating heart disease and stroke in our community. We have two amazing healthcare champions this evening that are going to present. And at this time, I'd like to pass the microphone to my soror, Dr. Awana, and she will present our first speaker. Thank you.
Good evening, everyone. Welcome to this webinar. I have the honor to introduce someone I've known for a long time, Dr. Natasha Harris. Dr. Natasha Harris is a seasoned healthcare professional with over 19 years of specialized experience in perinatal care, serves as a beacon of change in addressing racial disparities in maternal and infant health. As a registered nurse and international board certified lactation consultant, her expertise extends to founding the Perinatal Health Equity Initiative, a nonprofit dedicated to eradicating these disparities using a reproductive justice framework. Driven by her academic background, including a BSN, MSN-ED, and a DNP in educational leadership, she leads Ignite Maternal Health, focusing on postpartum and newborn nursing education. Actively engaged in esteemed committees and organizations, she conducts groundbreaking research, published in prestigious journals, shedding light on implicit bias in healthcare, breastfeeding disparities in the Black community, obstetrical violence, high-risk obstetrics, and reproductive justice. Dr. Harris's impactful work has been recognized by major media outlets, showcasing her commitment to advancing equitable healthcare practices for mothers and infants. We welcome Dr. Natasha Harris.
Thank you so much. Good evening, everyone. It is my pleasure to be here and talk about a very important issue on the last day of Black History Month and the last day of Heart Health Month. So my presentation is going to be focused on getting to the heart of the Black maternal health crisis and sharing some data and statistics about how things look nationally and in our home state here in New Jersey. Next slide. So I'm the founder of the Perinatal Health Equity Initiative. I founded the organization in 2018, really in response to the the Black maternal health crisis in our state. And I am proud of the work that we have done over the years. We have grown significantly and done really good work in the community. And so we look forward to expanding and doing more. Next slide. So every 2 minutes, a woman dies during pregnancy or childbirth. Next slide. In the United States, Black women are 3 to 4 times more likely to die than identical white women. And this is really our national lens. But if we look at different pockets of the state, you can see, or the country, you will see that those statistics are in fact worse. So here in New Jersey, it is 7 to 8 times. In areas of New York City, it is 13 times. And so the outlook for Black maternal health is pretty stark across the country. Next slide. We are doing the worst of all the developed nations. We continue to spend the most money on healthcare and continue to have the worst outcomes when it comes to maternal health. And so we rank in the bottom, similar to what third world countries would look like. And when it comes to the mortality rate as a country, we kind of leveled off a little bit in 2016, but we have seen every year since we have increased. And so this slide goes up to 2020, but new data coming out in 21 and 22 shows that this trend is continuing to go upwards. And so that's important to point out because we have spent a substantial amount of money, not just here in New Jersey, but as a country in addressing this issue. And we're not changing our statistics. And so that's something we really need to be paying close attention to. Next slide. This is the most recent data from the CDC, and you can see in the middle here, Black women continue to rank the highest in maternal deaths. So going all the way up until 21, we did see this really awful spike during COVID that started in 2020, continued in 2021, and continued past, continuing to rise in 2022. And you can look at us in comparison to white and Hispanic women. It wasn't until 2020 or 2021, I believe, that statistics for Hispanic women began to rise. And so they had always typically been a protected and safe group. And so the fact that their data is now beginning to change is also very troubling. Next slide. So when it comes to preventable deaths, this slide is also very important to look at, and I will get into more context, but in 2016, 60% of all maternal deaths were preventable. In 2021, it jumped to 84%. And here in New Jersey, specific to Black women, 92% of all of our deaths were deemed to be preventable. So that is almost all of them. And that's important because that means there is something that we could be doing to fix it. Next slide. So what are the leading causes of maternal mortality in the US? Next slide. For all people, you may have heard stories about mental health conditions. And so I have that highlighted here, but I want to draw your attention to the racial demographics here, where that is highest for white women. Next slide. On this slide, you can see it blown up by ethnicity of Black women, and mental health conditions was not our leading cause of death. Our leading cause of death was coronary and heart conditions, mainly related to hypertensive disorders. And so as we're beginning to do work, it is very important that the corrective actions that we are making are going to actually impact the group that is having the worst outcomes. So what happened as a result of this data being shared is we poured a lot of money into mental health support and suicide prevention, and that is very important, but that wasn't going to change our statistics. And we really have to be looking at what's causing our women to die in order to be able to change the trajectory of death. Next slide. So what about morbidity? Morbidity is basically you didn't die, right? But there are severe complications. So maybe there was a postpartum hemorrhage that maybe resulted in a loss of a uterus, for example. Those incidences are actually much more common than death. And there aren't any initiatives in our state or really from a nationwide perspective that are focused specifically on preventing morbidity. We've gotten very focused on death. And while the numbers are not great, total between 2016 and 2018, I think we had something like 69 women die total, whereas the rates of morbidity are significantly higher. Next slide. So pregnancy and the heart. Next slide. So pregnancy is basically a stress test. While the individual that is pregnant is growing a baby, there are a lot of additional changes that happen within the body. So your blood volume increases, stroke volume increases, which is basically the work that the heart is doing to pump blood. And what we have learned is that people who were either undiagnosed or very susceptible to developing cardiac conditions, they kind of unveil themselves as a result of the pregnancy. So people who have maybe had chronic hypertensive disorders or may have been prediabetes, we'll see these results come up during pregnancy. What's also very important to know is that Medicaid during the pregnancy is when people often become eligible for insurance. And so people who may have not have been under care previously are now receiving that care, and these additional issues begin to arise because they have healthcare that's paying attention. Next slide. And let's talk about hypertension pregnancy. Next slide. So this number is very, very important to me because I spend a lot of my time correcting it, unfortunately. There used to be a standard of 160 over 100. That was our range that we would say someone was hypertensive disorder during their pregnancy. That has since been changed, and it is now 140 over 90, so dropping that number. I am still seeing the use of the old number being used. Also, what's important to note that is not both of these numbers that need to be elevated. It only needs to be one. And so it could be on two separate occasions and at least 4 hours apart that that diagnosis is then made. The difference is whether this happens as a result of the pregnancy or if it was existing prior to pregnancy is based on gestational age. So if someone is 20 weeks or more when they are diagnosed, the likelihood is that it developed during the pregnancy. If they are diagnosed before 20 weeks, it is likely a chronic condition that happened prior to pregnancy. Next slide. And so what's the connection between the heart and Black maternal mortality? Let's get into that. Next slide. So from the headlines, you will see what these two people have in common. If you're not familiar with Tori Bowie, she was an Olympic athlete. She passed away last year from complications from preeclampsia. She died, unfortunately, in the throes of labor at home alone, and she was not discovered for 3 days after. And she was approximately closer to 6 months pregnant. Both her and Beyonce experienced episodes of preeclampsia. In Tori Bowie's case, she progressed to eclampsia, where she had a seizure, which occluded her airway. As a result, she passed away. And so one of the things that struck me, one, about how horrific that is to die in that way, but also the importance of checking on our pregnant folks. To not find her for 3 days means that she disappeared and people didn't check on her. And that's super important that we make sure we're checking on our pregnant folks. Next slide. And this same slide here, talking about Allison Felix, also an Olympic champion. And those two, this slide here is important to note as well, because these are people who are at the picture of their health, right? They're fit, they eat well, they take care of themselves. And so to see this as the image of Black women is important, because the narrative is often that we don't take care of ourselves and we've done something to cause it. And that is in fact not true. Next slide. So what we know is that the risk is not genetic. There is not something different about Black women that puts us at risk for preeclampsia. Things like social determinants of health, so things like where we live, eat, sleep, play, work, etc., impact our health outcomes. Exposure to racism, we know wears on our body. It increases the risk of preterm birth as well. Also increases the odds of developing a hypertensive disorder. Black women are more likely to deliver at a hospital that has poor outcomes. I encourage everyone to go on the New Jersey hospital report cards and look at what the hospitals are presenting in your communities. That information is public, although not often talked about enough, but you can see what the stats are in those respective communities. And it's no surprise that hospitals and communities like Camden, like Newark, have the worst statistics in the state. Another thing that's really important to point out is that while that might be true about the poor outcomes in certain communities, there is no income status that protects Black women from racism. So this is not an issue where you earn more and you're protected, or you have a higher level of education and you're protected. There is a concept called diminished returns, where those things actually provide protection for white affluent women. It does not do the same for Black affluent women. And case in point, Serena Williams' story and Beyonce, who had all the access and mean in the world, that didn't stop them from needing to advocate for themselves. Next slide. So a system of structuring opportunity and assigning value based on social interpretation of how one looks. It unfairly disadvantages some individuals and communities, while simultaneously unfairly advantaging other individuals and communities, while sapping the strength of society through the waste of human resources. And this is the definition of structural racism as defined by Dr. Kamara Jones, who has done extensive work in this area. Next slide. So the risk continues. Preeclampsia is in more than one pregnancy, doubles the risk of hypertension and stroke, triples the risk of heart failure and other cardiovascular events by 50%, and preeclampsia significantly increases the risk of cardiovascular disease, especially with a preterm and singleton birth. Next slide. Hypertensive disorders in pregnancy increase the risk of cardiac mortality. Black women have the highest rates of hypertensive disorders during pregnancy. Cardiovascular disease is the leading cause of death for Black women, both during pregnancy and in life in general. And 1 in 4 cardiovascular related deaths are preventable. So we can actually do something to prevent this. Next slide. I'm sorry, give me 1 second. Okay, she's coming. Sorry, I had to order food for my kids. Hypertensive disorders increase the risk for future cardiovascular disease, diabetes, chronic hypertension by ×4 during the first year of postpartum, heart failure, stroke, ischemic heart disease as well. And this continues not just during the time of the pregnancy, but for 10 to 20 years afterwards. Next slide. This is a recent article that came out from the New York Times. It really talks about how the complication cycle continues. So a mother who has this complication during her pregnancy, her children are now more likely to be impacted by those same outcomes. So 2 quotes that I was struck by the time they are 12 years old, these children are more likely to be overweight or diagnosed with high blood pressure, high cholesterol, or high blood pressure compared to mothers who had complication-free pregnancies. And then when these girls become women and they themselves get pregnant, they are already more likely to have hypertension and diabetes in pregnancy. And so the cycle continues. Next slide. Cardiomyopathy. This is a condition of heart failure during pregnancy. It's someone who basically had a healthy heart previously, but the stress of the pregnancy then results in heart failure. It can occur during the pregnancy or typically within 5 months after. In Newark, there was recently a heart transplant that happened of a woman that during her pregnancy revealed a cardiac defect that she had, and she was fortunate enough to be on the list and have a heart transplant, which is a story that was shared this month. And so the cause is unknown, but possibly genetic. And of course, with most things, Black women have the worst outcomes. Next slide. Let's move into preeclampsia. So preeclampsia is defined by 2 things. One, a hypertensive disorder during the pregnancy, but then also has some sort of other end organ dysfunction. So protein in the urine, which means the kidneys are involved. It could also include the lungs, so where there's fluid coming into the lungs. Liver enzymes could be elevated. And so then it can also progress to a seizure, which is a rare but serious complication of preeclampsia as well. Next slide. And so when it comes to Black women specifically, nearly every type of severe maternal morbidity is more likely among Black women with preeclampsia. So things like a heart attack, a stroke, and inpatient mortality. African immigrants do not bear the same risk as US-born Blacks, and that's a very important distinction because it really highlights the racism in this country. It is not until their next generation that they usually start to see these same statistics as Black women. So this is a true US issue. There are lots of gaps in research to practice, which I will talk about in a little bit. And then the other is postpartum visits are still happening at 6 weeks. The recommendation has changed to 3 weeks, but we're still seeing many families still be encouraged to come in at 6 weeks despite having these complications. Next slide. So there are separate risk categories, and I won't go through the list, but basically many Black women will fall into one of these 2 categories. You only need to have one in this existing history here. And so I want to point out a history of preeclampsia being one of those things. If you've had preeclampsia in a previous pregnancy, you are high risk for developing preeclampsia again in a second pregnancy. And so the care of that individual should be modified based on those statistics. Next slide. In the moderate risk category, you need to have 2 or more of these. So if you look again, if it's your first pregnancy and you are Black, you are at risk, right? So that is going to put positive, most Black individuals are going to be at moderate risk for developing preeclampsia. So even though we know this information, we're not managing care in the way that the data tells us we should be monitoring for it. Next slide. Prevention. We know that prevention is better than treatment. And one of the things that we can do is give baby aspirin. It is 81 milligrams, the same type of aspirin that's over the counter. While the science is not quite clear exactly on how it works, we know that it needs to be given as early in pregnancy as possible. So up to 28 weeks, but ideally within 11 to I think 16 weeks of pregnancy is the ideal range to give it. I am consistently encountering families who are not started on aspirin, even though they have met screening criteria to have been. I have a client that we're working with now who the doctor said, we think you're at high risk for developing preeclampsia, did not provide her a blood pressure cuff or start her on baby aspirin, yet identified the risk. Next slide. So what does it do to the pregnancy? It can decrease amniotic fluid. It can cause a placental abruption. So this is when the placenta actually separates from the uterus. This is a life-threatening event. Increases the risk for preterm birth. And so this is our connection to Black infant mortality. Preterm birth and low birth weight is the leading cause of Black infant mortality. We in New Jersey have the highest racial disparities between Black, white, infant mortality rates with a few of our local cities, Newark, East Orange, Irvington, Jersey City, Patterson, Atlantic City, and Camden being the highest in the state. And so it also restricts the growth of the baby in the uterus, making them smaller at birth, again, contributing to a low birth weight, which increases infant mortality. Next slide. So things that we encourage families to look out for. The one I see most common is a non-remitting headache, which basically means no matter what you do, this headache does not go away. You can't lay down, you can't hydrate it, you can't take medication. And this is the one that people tend to ignore the most, thinking that if they lay down, the headache will go away and they'll feel fine in the morning. And while I don't love creating a scenario of fear, I am a realist. In many of these women's cases, tomorrow does not come. So you cannot wait until tomorrow. This is something that needs to be addressed now. So not going to an urgent care center because they are ill-equipped to handle OB emergencies. It is an emergency room that you want to send someone to. The other one that I find that gets dismissed quite often is swelling in the hands and face. Your body does swell during pregnancy, right? You're taking on extra fluid, but your face and your hands should not be swelling. And that's often dismissed as a normal complaint of pregnancy, and it is in fact not. Shortness of breath, we know, is another one that, you know, as the pregnancy is growing in the body, you don't have as much room to expand your lungs. So you are a little bit winded. And so that's also another easy one to pass off as a normal complaint of pregnancy when it is in fact not. So when we know that our families have these increased risk, when they come and present with these symptoms, we should be screening and checking for these conditions to make sure they get treatment as early as possible. Next slide. Delivery is not the cure, and this is really important because we are seeing a rise in postpartum preeclampsia, especially in women who never had preeclampsia at all during their pregnancy. They were never diagnosed, but during postpartum, it's popping up. And so it used to be believed that once the placenta was delivered, which is believed to be the cause of preeclampsia, it's a malimplantation or malformation of the venous structure in the placenta. And so while we have delivery and the placenta is out, we are still seeing these cases of postpartum preeclampsia happening. Next slide. And so treatment, just briefly, is based on severity. If someone has preeclampsia with severe features, they do use magnesium sulfate. And I always like to point out to people that it is not a blood pressure medication. It is specifically designed to quiet the central nervous system to prevent a seizure. It is not meant to lower the blood pressure. It's not a blood pressure medication. Next slide. Postpartum preeclampsia, again, can arrive without prenatal history, most commonly within the first 7 to 10 days, but can be as far out as 3 months. And it is more deadly when occurring postpartum than it is during the pregnancy. Next slide. In severe cases, again, are more common during postpartum. Delivery is not the cure. And then we know that the clients are already home at this point. So when we look at our rates of death, most of them are happening within the first 3 months postpartum. That is, you can have them happen within the first year, but more commonly, they're happening within the first 56 days of giving birth. And so that's the time when our families need the most attention. Next slide. HELP syndrome is a complication from preeclampsia, and it basically is a condition where the red blood cells are destroyed, platelet levels are very low, and then there's elevated liver enzymes. And this is a picture of Amber Rose Isaac, who is passed away in 2020 from HELP syndrome. If you have not seen Aftershock, I highly recommend watching it. As a clinician, watching her labs on screen infuriated me because I could see that she was in HELP syndrome. And any provider, if you know anything about OB, you could see that this woman was in HELP syndrome. Yet they still decided to do a C-section on her with no platelets. And so, of course, she hemorrhaged to death. And so being attuned to these things, again, when we talk about prevention, this could have been taken care of before she needed that emergency C-section, but it was never addressed. Next slide. Strokes impact 30 out of every 100,000 births. Black women are 6 times more likely to experience one. And so we are very mindful of teaching people about those signs and symptoms. Next slide. I want to touch on breastfeeding really quickly as a factor to reduce cardiovascular disease. Next slide. Breastfeeding, we know, is a human right, and it's not simply a feeding choice. And we don't talk enough about the impact of not just the health of the mother, just the health of the baby, but also that of the mother that is directly impacted when someone breastfeeds. The more you breastfeed, or the longer the duration, it's a dose-dependent effect. The longer someone provides breast milk, the longer the benefits they receive. Next slide. So reduces the risk of breast cancer, which Black women are more likely to have aggressive forms and die from. Same thing with ovarian cancer, reduces the risk of developing type 2 diabetes and now cardiovascular disease. Next slide. And so there was a study that came out in 2022, and one of the highlights that I wanted to share with you is that the risk for developing maternal cardiovascular disease and stroke and fatal cardiovascular disease compared with women who had never breastfed decreased significantly with lifetime durations of breastfeeding up to 12 months. So breastfeeding, and this is each pregnancy, right? You can breastfeed one child for 6 months, do another one for 6 months, and you've met your 12. But it's a lifetime duration of 12 to 48 months that made the most impact on the heart. Next slide. And so it's time to take action. Next slide. And so here are 5 things that you can do to keep Black mamas safe. 1, deepen your understanding of the disparities and their cause, really understanding that it is racism and not race that really impacts these outcomes. You can join our monthly giving program. Our organization has a program called Cuff It that is specifically designed to fill in that gap with preeclamptic patients. We watch them during the periods when they are most at risk. We have saved many lives in doing that by getting people into care very frequently, providing them with blood pressure cuffs, calling providers, and getting action onto medications they may have need. You can also sign up for our newsletter. We do a number of different events. Black Maternal Health Week is coming up in April. We would love to have you involved in that. Spread the word. What is shared here should absolutely leave here and be told to another Black mama in your community. And then think out of the box for baby shower gifts. More often than not, the baby is supplied with everything they need. The mother is not. think about providing things that will reduce her stress. So providing her with a doula, providing her with lactation support, someone to help clean up after delivery. Those are things that are going to be really impactful in reducing some of these outcomes. And so with that, I will close. I think the last slide is just a thank you and a call to action to join our newsletter if you so desire. We would love to be able to interact with you outside of this space. Thank you.
Wow, thank you so much, Dr. Harris. That was a wealth of information, and we really appreciate hearing it. I really like that call to action that we do not keep this information amongst ourselves here, but we share it as much as we can with others. We do have a question in the chat, but as I read the question, and of course, you're going to give me the answer, could you also put your website down? I would really appreciate it in the chat for some of our folks. And I'll begin with the first question. Do you have any resources for moms with hypertensive symptoms when they're in the ER?
We are working on developing our own materials, but there is an organization called the Preeclampsia Foundation that does have some information that's printable on their website that you can guide. And so really what we do is advise personally what should happen is that we ask them to call an OB consult so that someone has expertise in the OB area can come down. We do have now in our chart a question that asks, have you been pregnant within the last year? And that question is very important because the symptoms are different if someone comes in as a pregnant individual. But then we also teach our families cuss words. And what that basically means are ways to raise concern, saying that you are concerned, that this need is urgent, and that you need something to be done now. And so using those words will help to steer action. And we also don't recommend that mothers go in alone. If you can go in with someone else to be your advocate, to speak for you. And that's why this information is so important, not just for the mother, but everyone that surrounds her needs to know this information, because if she is in the throes of a seizure, she can't tell you what's happening with her. Other people need to be aware of the risk so that they can prevent that from happening. But that
Wonderful.
is a
Thank you so much.
resource we aim to share soon.
Okay, thank you, Jasmine, for that question. And Nastasia, we have a couple of other questions. One, I have to tell you, I like your definition of cuss words. I think those cuss words can be used and applied to any situation, any medical situation. This is urgent,
Yes.
right? Let folks know that we are serious about our health. So we have Celeste. She has a couple of questions. It's a long, I'm just going to dissect it if you don't mind. So she commended you on an excellent presentation, and she said that she had a question in regards to COVID. And
Mhm.
did COVID have any impact on the rise of maternal morbidities? Taken that Black women are more disproportionately affected by Black women are more disproportionately affected by COVID. And that was one question, and we have two more.
Sure. So with COVID, I think what we found is the pregnancy itself decreases your immune response. And so Black women were more vulnerable during pregnancy. But what we did find still is even though there was this rise that happened during COVID, it wasn't specific to COVID diagnosis. It was all the barriers that were put in place because of COVID. So people that didn't have access to care, when I point out Amber Rose Isaac's issue, she was receiving virtual support. And so because she wasn't face to face with a doctor and they weren't looking at her labs in the same way, things slipped through the cracks. And as a result, people died.
Right. So the other question has to do with this. Celeste mentioned St. Joe's. And do we know if St. Joe's has a initiative that can educate Black women with the benefits? So we're going to take it a step further and say St. Joe's and any other aspirin producer. Any initiative you know?
So no, and I think what I will say is where we are unique as an organization is we are developed specifically for Black women. That is the work that we do as a Black-led organization. And unfortunately, we have learned not to depend on hospital systems who have historically caused harm. If you look at St. Joe's statistics, they have a lot of work for improvement on their outcomes, specifically with Black women. And so we really encourage people to go to their community-based organizations. And this is not an income-driven program. We serve all women, regardless of your income level. But there are people who are really doing the work because they love Black women and want to see us thrive. Those are the spaces you want to seek out.
Okay, and I appreciate your answer, Nastasia, but I think she was referencing St. Joe's aspirin. Like,
Oh, the aspirin. I've not heard of that. I'm not sure.
okay. And this is for, in general, this is also Celeste's question, but she asked if this presentation can be shared with everyone.
Sure. I don't have a problem with that.
Okay, thank you. We have a lot, we have another, okay, we have some more comments about the cuss words. And of course, Dr. Arwana has given you many accolades and thanks you and both you and her both for being champions in this business. And thank you so very much. We have another question from Arnett. Can you explain the connection between racism exposure and preeclampsia, particularly for those who can pay for any doctor? Is it inherent stress, protection, or racism in the care? For example, such as sensitivity to pain.
It's a combination of those things. Racism is very insidious in how it shows up in spaces. So there's definitely the weathering that we know of having to constantly deal with racist situations. And when it comes to wealthy Black women who are more in spaces where they have to be exposed to racism more often, which is a part of that connection. But we know that that stress on the body increases hypertension, which then increases the risk for preeclamptic disorders. And so it is one of those things that there's some science to it, but there's also the concept of knowing that racism and the experience on the body does contribute negatively to health outcomes.
Okay. I have some more questions for you, Dr. Harris. So, of course, thank you to you for talking a little bit more about those words. Okay, I'm sorry. Okay, here we go. The Biden administration, specifically VP Harris, raised awareness around this. Did they
Mhm.
launch an initiative? And if so, has it been impactful?
So they did write a plan for Black maternal health, but it is still fairly new. I want to say it came out in like 2021. And so the plans are great, right? We have a plan of what to do. Where I think we fall short is we don't have an implementation strategy and we don't have funding connected to it. And the way we fund in our state in particular is the consortia tend to get a large sum of the money of the work that's happening in the state, and the grassroots organizations are not funded the same. And so who is doing the work matters significantly with our outcomes. And I think New Jersey is a great example of that. When I started this work in 2018, our state was ranked 47th in the nation. So one of the worst for maternal health outcomes. At that time, Black women were 7 to 8 times more likely to die. In 2024, we are now ranked something like 29th. And so if you stop there, that sounds great, but I'm going to add that Black women are 7 to 8 times still more likely to die. And we have spent substantial millions of dollars trying to fix that. And a lot of that has to do with who is holding the work. I'm going to say this here because y'all are a group of Black women. No one loves Black women more than Black women. And we have the answers. However, we are not being funded to do the work in the same way the white organizations who hold more power and resources are. Our goal as an organization is to extend what we're doing to be able to take on these larger grants and make a bigger impact. There is structural change that needs to happen. We're focusing too much on direct service issues, but if we don't change policy, we don't have accountability in place. A doula is a great support person, right? But you're sending 2 Black women into a system who can care less about both of them. So until we fix that, we're going to continue to have these same outcomes happening.
You're completely right. And you know what, Dr. Nastasia Harris, I appreciate you. Our chapter appreciates you for presenting. I know you have another commitment. So,
Mhm.
with that being said, we're going to release you. But I think it's very vital for us all to keep in mind that look at the data, but stratify it by race and then look at it again. You know, the data is what it says, but when you look a little deeper and beneath the surface, you'll see different things. So we're gonna now pass the microphone um, to our Suram Mia, are you on the line still? I don't see you, but I'm sure you're here for our next introduction.
Yes, thank you so much, Dr. Harris. What a wealth of information that will definitely help our communities. We would like to introduce our next speaker this evening. We have with us Valerie N. Pogue. Valerie has been working in the health promotion field for over 20 years. She is a three-time graduate of Rutgers, the State University of New Jersey, where she studied public health and nursing. She is a certified corporate wellness specialist and is currently pursuing her MBA at Howard University. Valerie is a nurse well-being specialist for MedStar Health, where she is responsible for nurse and associate well-being in the clinical setting. She is a founding member of the Black Nurse Collaborative Incorporated, a co-crew leader for her local Girl Trek walking crew, and a proud member of Delta Sigma Theta Sorority Incorporated, Hartford County Alumni Chapter. Valerie is passionate about wellness and welcomes every opportunity to help people live well and be well in the spaces and places they occupy. Let's all welcome Valerie N. Pogue.
Thank you so much. It's an honor to be able to be here and talk with you all over the next 20 or so minutes about heart health. And, I want to thank Dr. Harris for setting the stage because she talked about the fact that heart health, blood pressure, these are all things that we have to worry about at different walks of life. We talked about children being impacted, we talked about pregnant women, and now I'm really going to be talking about the general population. So my presentation is entitled Getting to the Heart of Blood Pressure. Next slide. So just a little bit about tonight's agenda. I'm going to do a wellness check-in, give you some fast facts or some statistics, and I'm going to talk to you about blood pressure basics, understanding your numbers, monitoring your numbers, and then what it looks like to manage your heart health, and finally end with questions. Next slide. So this is an opportunity for all of you to get involved. I'm not sure if I'll still be able to see the chat, but I want you to give me a thumbs up or a thumbs down based on each question. So the first one is, have you had your blood pressure checked within the last 12 months? I saw one, there's a thumbs up. Excellent, okay. See a couple of you. All right. The next one is, do you know your blood pressure? So you've had it checked, but do you know what it is or what it was when you had it checked? Thumbs up, I see a couple. Okay, good. The next one, do you know what category your blood pressure falls under? Okay. I see a bunch of people who need to be given this instead of me, so you're on it. Okay, I see a couple of no's in the chat. That's all right, we'll talk about that too. And then the last question is, do you have a personal or family history of high blood pressure? Personal history means that you have experienced it before, and then family history, obviously, in the genes. Okay, I see some yes in the chat, some thumbs up. Okay, excellent. Great. Okay, so we've got a mix of yes and no's, and that's okay, right? Because tonight is all about education and promoting awareness. So when we know better, it doesn't necessarily mean we're going to do better, because knowledge doesn't equal behavior change, but we know that now we're going to be motivated to want to do better. And the reason I asked about those things is because of this slide right here. So about 55% of Black adults have high blood pressure. Okay, so 55% have hypertension. The most common symptom of high blood pressure is no symptom at all. That means we can walk around feeling fine and not necessarily be fine. Only 1 in 4 Americans, 25%, with high blood pressure have it under control. And then lastly, African Americans in the US, which Dr. Harris was talking about, right, specific to the US, have a higher prevalence of high blood pressure than any other racial and ethnic group. And so we are at higher risk for this. And as she talked about, a lot of that is structural racism. Next slide. So now we're going to get a little bit into understanding your blood pressure. Next slide. So I'm not going to go into the clinical understanding of blood pressure and what it means and the valves and all of that. What I want you to know is that your blood pressure consists of 2 numbers. There's the top, which is your systolic, and there's the bottom, which is your diastolic. That's the only thing I want you to know. There's two numbers, because in order for you to understand your blood pressure, you have to know what it is that you're getting. Next slide. So, and I asked you this earlier, right? Did you know what it was, right? So you know that there's two numbers. So if somebody says that your blood pressure was 110, you know that that's not your blood pressure, because we're supposed to have two numbers, right? Perhaps that might be your heart rate. Blood pressure categories now. So what does it all mean? So if somebody gives you those two numbers, it's important for you to understand, well, what's that all about? What category do I fall under? So much like Dr. Harris was talking about when it comes to high blood pressure in pregnant women and the standards changing, they do the same thing with everyone else. So at one point, 120 over 80 was pristine. That was the blood pressure that everybody knew about, right? That was the goal. So what they do is every couple of years, based off of trends of what's going on in the country, they will lower them or they will change the readings for that, right? Because the goal is to get people before they get too high. So right now, a perfect blood pressure is about 115 over 70, 75, right? But I'm going to tell you, as someone who takes blood pressures, if somebody sits in my chair and they are 120 over 80, I'm not writing down that they're elevated. I'm writing down that their blood pressure is healthy or it's normal. But what happens is, as you can see underneath the normal category, what's normal now is less than 120. So that top number is less than 120 and that bottom is less than 80. And I'm telling you these things so that you understand when your blood pressure is taken by a healthcare provider, when they put that into the chart, that's your medical record, right? That's a document. If you start to get things or you get calls saying that you're elevated, it is because they're following the blood pressure guidelines and the categories, right? So it's really just understanding where you fall. And like Dr. Harris talked about, only one of those numbers has to be outside of the healthy range, and that's going to determine where you are. So for example, let's say that you are 120 over 90. That's going to put you at high blood pressure stage 2 because of that higher number. Now, also understanding that one high reading does not make you someone who has high blood pressure. It is consistent readings over time. It's really going to depend. Sometimes they want to do 3 different readings at 3 separate times over 3 months. But understanding, you can go into the doctor's office or healthcare provider's office and your blood pressure is elevated because perhaps you just got out of a stressful meeting, or you were sitting in traffic, or you were sitting in the waiting room 30 minutes past the time that you were supposed to be seen. And we know sometimes that can elevate our blood pressure. So again, making sure you understand it's a series of readings over time, but it's important for you to know what it is. So when you go to the healthcare provider's office next, or if you're having it taken, in a pharmacy, you want to make sure that you know what it is, so then you can kind of compare it to these different categories. Next slide. So now that we understand it a little bit, we want to look at monitoring it. So when you go to a healthcare provider's office, and just for clarity, when I say healthcare provider, that is any type of practitioner. That could be a nurse practitioner, that could be a physician's assistant, it could be a CNA, it could be an LPN, it could be an MD, it could be a DO. I want to make sure that that is encompassing of all the different practitioners that we might see. So when you go into a healthcare provider's office, there's certain things that I would like for you to do from now on, if it's not something that you do already. One, ask them to take your blood pressure manually. I understand that sometimes when we go into the doctor's office, we have it and it's taken electronically, and there's nothing wrong with that. But I think it's important, especially if you have a personal or a family history of high blood pressure readings, that it is taken manually. We put that stethoscope on and we're auscultating, right? Or we are listening for your blood pressure. I think it's important. So if it's done electronically in the beginning, then before you leave, make sure you ask for a manual blood pressure. The other thing is, ask if you can have your blood pressure taken after you've settled. Again, I know when I go to my healthcare provider's office, I've been sitting in the waiting room, right? So that might have me a little bit agitated. Then I go to the intake person and they make sure they have my card on file. Then I go sit back in the waiting room. Then I get called back to the doctor's office, and then I'm stepping on the scale. I am having my temperature taken. I'm having all these things done at one time. And then it's like, oh, okay, your reading's a little high. Well, I've just been moving. I've been doing a lot of things, so I haven't had time to settle. So one of the things that I always ask is, can you give me time to settle? The next thing is, Always ask for your blood pressure reading and write it down or put it in your phone. Make sure that you're keeping track because it's important for us to understand the trend. One number is not enough for us to say, oh my goodness, I'm at risk. Perhaps I have high blood pressure, but it's important for us to look at the trend. It's important for us to notice, what, when I'm at the doctor's office, it's a little higher. Perhaps I have something called white coat syndrome, right? Which is a real thing. It's where people get nervous when they know that their blood pressure is being taken. Or I notice that when I take it at home, it's higher, or vice versa, it's lower at the doctor's office, whatever it is. But I think it's important for you to write it down so you know what it is, write down what category it falls under, and then also write down the environment in which it's taken. Is it at home? Is it at the healthcare provider's office? Is it at a health fair? Is it at a pharmacy? And then lastly, if you are someone who has a blood pressure cuff and you are asked to monitor your blood pressure at home, I want you to make sure that when you get a new blood pressure machine, that you take it to your healthcare provider's office and have it calibrated or have it checked by them. And what that means is they'll take it at the doctor's office, they'll wait a span of time, and then before your visit is over, they'll take it with your machine to make sure that the levels or the readings are similar. Next slide. So now I want to talk a little bit about if you are someone who is required to monitor your blood pressure at home, or it's just something that you do because you like to stay on top of your numbers. The American Heart Association, who's a great resource, has information on really how a blood pressure should be taken. And so for the purposes of time, I won't go over everything, and I know these slides will be shared, but you want to make sure, again, that you have a valid monitor. And I know sometimes questions I'll get is, does it matter where you get it from? I want to tell people that in the pharmacy, in the back, when you go to pick up your medications, they got a lot of great brands. Of course, we've heard of things like Omron, that's a really good brand, but I tell people it's about what you can afford and just make sure that it's checked by your healthcare provider. I also don't recommend using wrist cuffs because they are not as accurate. If you can get an arm cuff, that's the best one that you can get. But again, if a wrist cuff is all you can find, then again, make sure your doctor checks it out, and then you can absolutely use that one. So 30 minutes before your blood pressure is taken, if you're taking it at home, and this even works at the healthcare provider's office, no smoking if you're a smoker, no exercise, no caffeinated beverages, no alcohol. All of those are things that can have an impact on your blood pressure. They don't necessarily have to, but they can. And so that will impact your reading. 5 minutes before, again, and we talked about this, make sure that you're settled, that you're sitting still, you're in a chair that does not roll, no wheels, but it's a stationary chair. And then right before, you want to make sure that the cuff is the right size. This is anywhere that you go, because if it's not, it can give you a misreading. If it's too small, it's going to squeeze harder than it already does, right? It's not going to give you the right numbers, the same if it's too big. And you want to make sure, again, that the blood pressure cuff is put around as close to the skin as possible is what they would like. But if for some reason you can't, you want to make sure that it's thinner attire. Okay. Then while your blood pressure is being taken, you want to make sure that you are relaxed. And I know that's hard because you have something that is squeezing what seems like for dear life, but you want to make sure that you're relaxed. Don't talk. I know sometimes healthcare providers want to talk to you while you're taking it. Make sure it's a quiet, relaxed environment, and make sure that your arm is resting comfortably on a flat surface. You also want to make sure that your feet are flat on the floor. I know sometimes they will take it while you're sitting on the exam table. Well, if you cannot put your feet flat on the floor, they're dangling. So these are all things, again, that you want to take into consideration when you're having it taken for you or you're taking it at home. And again, after you've taken it, if you don't necessarily like the number that you see, wait a minute or two, try and calm down. Because sometimes the first reading is the anxious reading, right? It's the I'm hyped up, I know I'm taking this. So we want to give it a little bit of time. And then, as always, keep a journal, keep a log, write it down somewhere so that if you go to your healthcare provider's office, or if you were at a health fair or somewhere else and you're having it taken, you can say, this is a little elevated for me because normally I'm this. Or you can say, wow, this is really good blood pressure. Normally I'm not this. So it's really important for you to pay attention to the trends and to track them. Next slide. And so there's 4 questions that you want to make sure you're asking your healthcare provider at every visit. And we've gone over them, but I think it bears repeating. The first one is, what was my blood pressure reading and what do the numbers mean for me, right? It's individual. So you want to know if I'm 120 over 80, what is that saying, right? You want to make sure you get two numbers. Two, how often should I have my blood pressure checked? That's also individual. For some people who have perhaps previous personal history with blood pressure, they may want you to have it checked annually or maybe twice a year. For other people, maybe it is 3 or 4 times a year. It's really just going to depend on what your social history is, what your family history is, and what your personal health history is. The next one is, how can I control my blood pressure if it's high? So if you do have high blood pressure, you know, it really depends on how high it is. Sometimes healthcare providers will say, all right, it's elevated. And so I'm going to give you 3 to 6 months. And here's what I want you to do: exercise, lifestyle changes, monitor your sodium intake, things of that nature before they put you on medication. Others will not take the risk and they might put you on medications. But I want you to make sure that no matter what, it's a dialogue with your healthcare provider. I know from a historical context, African Americans, we are not trusting of the healthcare system, and for good reason, right? But in this case, I want to make sure that you're prepared for your visits, that you know what it is that you want to talk about, write down your questions, because we understand that with managed care, a lot of times you get 10 to 15 minutes with a provider. So make sure that you're prepared. And if you don't understand something or you want to know something, ask the question, because again, they can only tell you what to do, but you are the one who actually has to do it. And then lastly, asking if there are any medications that can affect my blood pressure. So if I'm taking, vitamins or other natural supplements, can they impact this prescription medication that I'm taking? And if so, how? If you don't get an opportunity to ask your healthcare provider, you can always ask a pharmacist. Next slide. So now we're going to talk about managing your heart health. We've talked about blood pressure and how important that is to our cardiovascular health. But the American Heart Association has something called the Essential Eight, right? And this is all about maintaining your heart health. The first one is eating better when we can. We understand that there are celebrations, right? So maybe we want to eat that cake, that sweet food, that salty food. And we understand that there are times where we're using food, right, as a coping mechanism. And so maybe we don't want to eat the healthiest of things. But when we can and when we have the financial ability and the access to do so, we want to make sure that we're eating the whole grains, that we are watching our sodium intake. And the amount of sodium that you are allowed to have is really going to depend individually on your health history. We need sodium, we need it for the body to run, but we don't need as much sometimes as we consume. The second thing is to be more active. If you have a gym membership, that's wonderful. If you don't have a gym membership, that's okay too, because there are things that you can do around the house or in your neighborhoods or in your communities. The goal is just to move. You can stand up and sit down 5 times, and that's like doing a squat. You can walk around your island. You can go up and down the stairs. You can march in place. The goal is to make sure that you're not sedentary. And I know still in this remote environment, some of us are sitting in front of our laptops all day. We may not really get the opportunity to get up and move. So just make sure you're moving. If you can't necessarily get up, maybe you have some hand weights or you use water bottles, right? And you're just moving your arms. You're doing different things to make sure you're moving your body. Quit tobacco. It's just that straightforward. There isn't much to say about that. We know that smoking is not good for us, and we know the things that it can do to the body. So again, it's really making sure that you set that goal to quit and you do so. And understanding it takes about 6 to 9 lifetime quit attempts. It is a very hard thing to do, but there are resources out there. 4 is to get your sleep. It's actually Sleep Awareness Week coming up March 10th through 16th. We know that we're going to be springing ahead, which means we're going to lose less sleep at night, right? So there's so many things that can impact our sleep. So it's important that when you can, you get your rest. They say about 7 to 9 hours for an adult. Some people need less and they're able to function. But you know when you've not had a good night's rest, when you wake up sleepy, you wake up and you feel like I just can't get moving. But all of that impacts our heart health. Managing your weight, again, figuring out what a healthy weight is for you and for your frame. BMI is something that they use in the clinical setting, right, to determine whether or not you're at risk for certain chronic conditions. But we also understand that it's a calculation and it is not absolute, it's absolutely not the most culturally sensitive, right? So just being mindful of how much you weigh, where you should be, and what that does for your health. I know you losing just 5 to 10 pounds can lower blood pressure by about 5 or so points. Controlling your cholesterol and your blood sugar. Really, really important because we find that people who have high blood pressure may also be at risk for high cholesterol, may also be at risk for high blood sugar. So those three things tend to run together. Now, doesn't mean you will get it, but it can put you at risk for it. So making sure that you know what your numbers are, that you're getting them checked regularly as indicated by your healthcare provider. So doing all of these things is really, really, really important. The other thing I would want to add that's not on here is the importance of keeping our stress levels lowered, right? So make that the essential 9. Really, really important to make sure that our mental health is intact. Next slide. So we talked about a lot of great information. There's 2 numbers that you should know when it comes to your blood pressure. You want to make sure that you are having it checked regularly. You want to make sure that you're doing the things that you can do, asking your healthcare provider for additional resources. And I always like to end with a quote, and I thought this one was very apropos. We know that they say men tend to be the head of the household. Well, I like to say that women are the health of the household. So everything that we do or don't do really flows from us. We're the ones that make the appointments for our kids. We may also be taking care of parents and other elderly. So it's important that we also take care of ourselves. So Dr. Angelou said it best. When women take care of their health, they become their best friend. So that concludes my presentation. I want to thank you for your time and attention, and I'll turn it back over to the team.
Thank you so much, Valerie, for this wonderful information. I know we still have some questions. I know I'm thinking about all of the information shared, and if I can just ask, out of everything shared, what is the most important thing you want us to walk away with from your presentation about heart health?
I would say the most important thing is to know your numbers, and therefore that will help you to know your risk. And equally as important, right? All these things kind of come together, is also having conversations with family members. You know, a lot of things happen at the Black family table. We talk about a lot of different things, but it's important for us to also be talking about our health when you can. You know, asking, you know, your parents or older adults or anybody, hey, has anyone ever had this in the family? You know, I have a family history of cardiomyopathy. So it's understanding what my risk factors might be. So I think it would be those 2 things. I know you said 1, but I think those 2 would be the most important, knowing your numbers and also having those conversations with family.
That's really good you mentioned that, the conversations with family, because sometimes we don't always talk about these things and we don't know the questions to ask. And I'm trying to think, like, what specific questions would I ask to learn more about my family's history with heart health?
Sure. So you could maybe ask, you know, has anyone ever had high blood pressure before?
Mhm.
Right? Or is anyone on any medications for blood pressure? Perhaps if you're of childbearing age, you might ask, was anyone ever, you know, having high blood pressure during a pregnancy or things of that nature? You might ask, has anyone ever had a heart attack or a stroke? Anything related to cardiovascular health. Anyone ever had any deep vein thrombosis or DVTs, right? Blood clots, all of those things are really, really important for us to ask. Was anyone ever a smoker? Do we have overweight and obesity in the house? Any of those risk factors, high cholesterol, blood sugar, because they all tend to run together. So those are some of the things I would ask. And if it's not in your generation, is it in the generation above you or the ones, you know, above them?
Thank you so much. I'm just taking a look at the chat and looking at all of the comments about how informative the presentation was, and I definitely agree with that. I want to thank you again for joining us this evening, and I would like the opportunity to share this presentation to people who may not have made it, and because I think it's a great message to share with our communities, if that's okay.
Yes, absolutely.
Okay, thank you. Now, at this time, we have our president, Madam President of Central Jersey Alumni Chapter, who will be able to offer remarks, closing remarks for our heart-to-heart conversation with CJA program this evening.
Thank you, Soa Kirk. Good evening, everyone. My name is Patricia Williamson, and I am the proud president of the Central Jersey Alumni Chapter of Delta Sigma Theta Sorority Incorporated. I would just like to say thank you, because what I heard today was amazing. I was really hoping to get a chance to say hello to Dr. Harris, but I know she left, but the information she provided, I want to thank her. I want to thank Sora Pogue. We go way back, and this is very good information. We need to re-listen to this over and over again. These recordings are just for that reason. I also would like to thank Sora Kirk, Sora Williams from the Physical and Mental Health Committee, and Sora Shakira Lindsay and Sora Latifa Adams on behalf of Strategic Partnerships. These are the types of programs that we want to provide to the community. And yes, we are doing double duty today, but this is one of those where it's very close to my heart because I have a lot of family members with heart health issues. And so this is the type of thing, these type of tips and things that we need to look into so that we can make sure that we can stay as healthy as we can so that we can help others. So thank you again. And I will turn this back over to you, Sora Kirk.
Thank you. I'm glad we were able to hear from you. I know that you are very busy trying to do double duty at very important programs within the community. So thank you. So, Sora Laquanda, do we have a prize wheel ready? We would like to give a token of appreciation to one of our attendees in addition to the token that we will be giving to our wonderful presenters. I'm very excited about this program, about the message, about the action steps that we now have to advocate for ourselves and others. And at this time, I will give the microphone to Laquanda, who will let us know who our prize winner is for this evening.
Okay, the caveat is a prize winner must be present on the Zoom if their name is called. Just want to make sure I have all other names. And the committee for this event will not be in the wheel to make it fair to everybody. Okay, I am beginning to spin. Is Michelle Bailey on the Zoom? Yes, she is.
Hey, Michelle, congratulations. You are our winner.
Thank you.
So we will be reaching out to you to send you a token of appreciation, a little gift for attending this evening. Not only is Michelle a winner, but we all are because we have some new information and action steps to take out to our families and for advocacy for ourselves and others. So thank you again for joining us for this very important conversation, heart to heart with CJA. Again, take a look in the chat for the survey, and we will follow up with an Eventbrite message that will include some resources that people requested, as well as the survey link again. So thank you and enjoy the rest of your evening. Good night.